Good afternoon, everyone. Welcome to Session 7, COVID-19 Best Practices for Long-Term Care. I'm Susan Ryan. I am the Senior Director for the Greenhouse Project and really delighted to be partnering with Project ECHO, which is a wonderful platform that really leverages technology so that we can share best practices through case-based scenarios, and then we monitor our outcomes so we can get better. All teach, all learn, and that's what we're here today to do. Today's session, we really want to talk all about the latest in testing and everything you've wanted to know about testing. We've got a geriatrician, epidemiologist here who can really unpack that for you. And then Eric Reguera is going to share a bit about the experience of testing at Jewish Home Family. So really excited for that agenda. Before we get started officially though, Janet, I'd love for you to kind of walk us through the housekeeping announcements.
Sure. Thank you. Welcome, everybody. For today's session, you will be in listen-only mode, meaning that if you have anything that you need help with, you can put that information in the chat button, but you're not able to speak. We do ask that you share your screen so that we can get to know you and see who's on the call with us today. Please enter your name and the name of your organization in the chat box as well so that we can check out and see who's here with us today. And we will be using the chat box later for our question and answer session. The session will be recorded today, so for anybody who is not able to stay on for the whole thing or you just want to watch it later, you will be receiving a recording either later today or tomorrow. And thank you.
Thanks, Janet. Additionally, I'd like to introduce my colleague, Marla DeVries. Marla?
Yes. Hi, good afternoon, everyone. Marla DeVries with the Greenhouse Project. I will be back a little bit later to help facilitate the Q&A. So as you hear these two thought-provoking presentations, I ask that you put your questions in the chat box and we will utilize those a little bit later. Thanks.
Great. So before we get started, we're actually going to do our polls on the front end today. And first question, we ask it every time, but we want to know what part of the country you're calling in from. So if you would just take a couple seconds and let us know where you're calling in from. And of course, there's a box if you happen to be calling outside the US, there's a box for you too. All right, Janet, you can close the poll. Once again, I tell you, our Northeasters, they always show up plentifully. 45% are from the Northeast, and we have 21% from the Southeast. All right, next poll. Want to get the next one up. This is one we really wanted to understand what has been your single biggest challenge in the last 2 weeks. There have been many, all of these are challenges, but when you think about the last 2 weeks, what has been the biggest challenge for you? And you know, your responses really help us figure out what we need to be focused on talking about as we go forward and plan subsequent sessions. So think about the last couple weeks and where you have really struggled. Of course, I'd like to think we've figured out access to PPE, but you never know. So eager to hear your thoughts. Give it a few more seconds. All right, Janet, I'll let you close it. Managing visitation, the challenges of opening up for family visitation. And I happened to be on site at a community last week, and that certainly was what they would agree with you on. Workforce looks like that's pretty challenging as well. Additionally, a meaningful engagement of elders. Wonderful. Thank you so much for your participation in those polls. And now I would love Al Power. Dr. Power, if you would introduce yourself to the group.
Hi, everybody. Al Power, geriatrician, educator, consultant from Rochester, New York, and really looking forward to these two presentations today.
And thank you so much, Dr. Power, for always showing up and bringing your expertise. And now Eric Reguera from Jewish Home Family. Eric, if you'd introduce yourself.
Hi, good afternoon. Thanks for having me back again. My name is Eric Reguera from the Jewish Home Family. I'm currently the DO in here at the Rockleigh campus. We're located in Bergen County, New Jersey.
And thank you, Eric. We learned so much from your real life experience in the day in and day out. And we're going to hear more from Eric in just a few minutes. But I'd like Dr. Jonathan Evans to introduce himself. And then Dr. Evans is going to share his presentation on all things testing. Dr. Evans, it's a pleasure to have you here today. And you're on mute, so we'll just have you take yourself off. There you
Can
go.
you hear me now? Okay.
Good.
Thank you all very much for having me and for joining. I'm Jonathan Evans. I'm a, please call me Jonathan. I'm a physician and I'm a geriatrician, and I'm also an epidemiologist. And for the last seven months or so, I've been all COVID all the time, basically. So I wanted to talk to you about testing, which is a kind of a big topic related to COVID. And I've got a few slides here that I'm going to try to pull up here. Sorry, I'm kind of technologically challenged. Now, as this is loading up here, a couple things. First of all, we could talk forever about testing. This is what I'm hoping we can accomplish here. Is I want everybody to, after about 15 minutes, really understand basic concepts and necessary vocabulary related to. I got this wheel spinning around that I can't seem to get rid of here. I'm sorry. I'm kind of locked in. I'm locked in.
Do you want me
purgatory here.
to, I could share my screen, or Janet, do you have the
I
slides
have
up?
the slides if you want me to share them, Jonathan. You just need to prompt me.
Okay. I'm not, how do I do that?
Okay, I'll just go ahead and take over.
Okay, great. I'm just trying to get to where I can see them, but anyway. So basically, what I want you to focus on really is just some basic vocabulary, the concepts really, and really have a working knowledge of the different kinds of tests and some of the pitfalls and challenges and limitations of that, okay? If you wouldn't mind hitting the next slide here. Every one of you on the call has actually been tested for COVID, whether you know it or not. You've had your temperature checked. You've had symptoms. You've been asked about symptoms. The entire purpose of that when you entered a building or something was to see if you had COVID or not. Unfortunately, that's just not a very precise test for COVID. It doesn't distinguish between COVID and other infections. And lots of people can have COVID and not have a fever or any other symptoms. So as a consequence, other tests have had to be developed to be more precise. So the kind of questions we want to talk about are why test, how to test, how do these different tests work, what do the results mean, when, whom, and how often to test. And then I'll just make a few comments about people living with dementia and some of the challenges therein. We'll go to the next slide, please. So the reason why it's important to test for this is, COVID-19 is a very big deal. Hopefully I don't have to convince you of that. It's in the top 3 leading causes of death in the United States. And the reason why it's necessary to test for COVID-19 specifically under certain circumstances is in order to tell who's infected and who's not, because you can't be sure that someone is infected based on symptoms or not. And why do you need to know who's infected or who's not? In order to separate people who are infected from people who aren't, in order to prevent further spread of infection. And the other reason to test is to monitor and treat people who have COVID and see if they're still contagious or not, and make some other determinations. So I can't emphasize enough, it is absolutely impossible to know for sure if someone's infected with COVID based on how they feel. Okay, and the key thing there is that virtually everybody who gets infected with COVID will experience a period of several days where they have no symptoms, where the virus is growing in the body, but where they're contagious. So there's this period where people are either never develop symptoms and we say that they're asymptomatic, or a period where they haven't developed symptoms yet and we say that they're pre-symptomatic. And it appears that actually people are most contagious before they develop symptoms, which makes this particularly problematic. The other thing that I would point out is when people do develop symptoms, the symptoms are no different from other flu-like illnesses. So you just can't even the loss of smell or taste isn't entirely unique to COVID. So let's hit the next slide here. So then now the question is, how do you test for COVID? And so we're talking about a virus, okay? And so testing for COVID to see if somebody has COVID in their body involves identifying COVID components of this virus from a sample of that person's saliva or secretions from their nose or throat. The saliva tests were interesting because they're easier to collect, but they haven't really panned out as well. So most tests involve a specimen from the nose or the back of the nose or the throat. And the way that these tests are done is basically either identifying pieces of the virus or checking for an immune response to the virus from looking for proteins in a person's blood. Those are called antibodies. So basically, the bottom line is these current tests require collecting a specimen from a person, a part of you, if you will, and then evaluating that using some equipment. Most often that involves sending things off to a lab, but there are certain quick tests that have been developed. Many of you have already received them if you're working in a nursing facility or assisted living. And those tests can be done rapidly on site, either with a machine or just with the test itself. It may be kind of this freestanding card. And when a test is done on site where the specimen's collected, we refer to that as point of care testing. Okay, so we'll hit the next slide here. And so just as I mentioned, we're looking for pieces of a virus. So think about it this way. These viruses are essentially just packages of genes or, within a capsule. Now, so think in your mind about a medicine capsule, Tylenol or something like that. It has a gelatin coat, and inside you can see the little balls of the medicine. Okay, so that's kind of what viruses are like. There's nothing else to them. They're not complete cells. They're like parasites that rely on living organisms to hijack and basically take over the cells and make the cells produce more of the virus, essentially. And so so the way that these tests are done is to either identify pieces of the genetic material, which in the case of coronavirus 19, all coronaviruses, or COVID-19 specifically, it has RNA, okay, for what it's worth, ribonucleic acid as the genetic material. So you can either test for that or proteins on the capsule, or as I mentioned, you can test for antibodies in the blood of somebody who either is infected now or was previously infected, all right? So we'll talk a little bit more about how that's done. Now, the thing about it is these viruses are tiny. I mean, they're, maybe 10 or just a few nanometers, and these pieces are even tinier. So you can't just look at them in a microscope because they're too small. And even with an electron microscope, to prepare a specimen for looking at it under an electron microscope is going to take days at a minimum, if not longer. Okay, and so in order to have enough of the RNA or the genetic material to actually detect, a technique is used that's been around for at least 30 years, where essentially the idea is that the testing process multiplies the genetic material and through a series of reactions done over and over and over again, and that process is referred, or the specific technique used is referred to as the polymerase chain reaction. So you basically take a specimen that has the virus in it and you add stuff to it, you add ingredients to make more of it. It's like making sourdough bread. You have the starter and then you add the other stuff and you get more bread, okay? So that's the concept, but it takes a while to bake that bread. And so these PCR tests take a while to be done. They require these different components, these ingredients, which we call reagents, and they typically are done in laboratories. So as a consequence, a test like that takes hours at a minimum, and when you talk about sending it to a lab and back and forth, it may actually take days before you get a result. But this PCR test is far and away the most precise and reliable test that we have, but it's not foolproof, and it can miss some cases. And I want to talk a little bit about why that is. All right. Well, one reason is that you could be infected, but just not be making enough. Well, the main reason, you could be infected, but not be making enough of the virus, or shedding enough of the virus to detect it. The other could be that the specimen collection just wasn't that good. A nasopharyngeal swab is kind of unpleasant, shall we say, and in our desire to be gentle, sometimes we don't get enough of the nasal secretions. Okay, so I mentioned PCR tests are performed in certain labs. That takes a while. And these days, there's a lot of backlogs, which has resulted in the time to get test results being even longer, which ironically resulted in fewer tests being done. We can skip ahead here. I think I kind of covered that. Next slide, please. So now the antigen tests detect proteins on the surface of the virus. And these particular, by the way, by definition, an antigen is a protein where an antibody attaches to, okay? So the way it works is your body, the presence of this virus in your body causes your immune system to get turned on, and through the magic of the immune system, it makes these specialized proteins called antibodies that attach to certain parts of the virus, kind of neutralize it, and then the white blood cells basically destroy it. So basically, the way that these antigen tests typically work is that a testing kit has some antibodies in it, and you add the antigen, you add a specimen to it that might contain the virus, which means it contains the antigens, and then the antigen and the antibody combine, and that reaction, the antibody usually has something attached to it, like a fluorescent molecule or something, so that when you combine the two, after a while, a color change occurs or something like that. So these are fast tests, 30 minutes or even less, can be done anywhere. Nowadays, every nursing home and every assisted living facility either has or is getting some of these tests, courtesy of the federal government, to do periodic testing. The thing to keep in mind about antigen tests is they're not as accurate as the PCR test. And there was the first wave of antigen tests were far less accurate than the ones that are currently being used now. But the problem with the current antigen tests is that there's a higher rate of so-called false negatives, which I'm going to talk about in a moment, okay, as compared to PCR tests. So next slide, please. And we'll talk about false positives and false negatives in a minute. An antibody test, again, is a test of somebody's blood. It's measuring proteins that your body makes in response to the infection. Okay, now the problem with this is that there's different kinds of coronaviruses, and the antibodies to coronaviruses look pretty similar. And so some of these tests can give you a positive result because you were infected with some other coronavirus that maybe gave you a cold 2 months ago that you hardly remember. And so that could be what's called a false positive. The other thing is that you can't really tell if somebody has antibodies, whether they're still contagious or not. So they could have, it just tells you that they have been infected by a coronavirus at some point. I would just add to that the antibodies themselves can disappear over time. And so as a result, if you wait too long to get to antibody test after somebody maybe has had symptoms, you could have a negative test, even though a person might have actually had the coronavirus before. There was a hope several months ago that we could use these antibody tests to see if people were immune to COVID-19, but partly because they disappear and they're just not that reliable, it's really not safe to assume that just because somebody has antibodies to COVID-19 that they are actually immune. And there have been some rare cases where people have actually been infected twice. So next slide, please. So I mentioned some terms about false positives and false negatives. Let's talk about what that means. First of all, the way that these tests are reported is essentially yes or no. Yes, this either virus components are present or antibodies are present, or no, they're not. So if yes, they're present, then we say that it's positive. If no, they're not, means that there's negative. But the thing about it is, there is a threshold of how much of this stuff has to be present for the test to be able to detect it. All right. And so as a consequence of that, if there's only a small amount present, you could get a result that's negative. Or if it was related to handling of the specimen or how much nasal secretions were collected, it might be a bad specimen and you could miss something because the swab was bad, or it sat around for too long and that kind of stuff. So a false negative is basically where you have a negative result, but the person really has the condition. Okay, so and a false positive is a test where you get a positive test result, but the person doesn't actually have the disease. Some of you may have heard about other things where people talk about the sensitivity or specificity of the test. That refers to whether or not, sensitivity refers to basically whether the test is truly, how often the test is positive in disease, and specificity refers to how often the test is negative in health. Okay, we can talk more about that if you have questions about it later, but let's hit the next slide. I'm using up all my time here, so I want to make sure I don't hog the session here. And we'll go to the next one. All right, so then the question is, well, when should people be tested? Who should be tested and how often? And basically, it's easy to, as I mentioned, it's easy to check somebody's temperature. People get their temperature checked every day or multiple times a day if they live in a care setting. And so if the test for COVID-19 was fast and cheap and accurate and not uncomfortable, then the testing would be done more often. Okay, the testing has been limited up until now because there's, for the PCR test, for example, there just wasn't enough testing available. In fact, there's still not as much testing being done as is recommended in order to really monitor this condition in the country. It's estimated that, 3 to 5 times as much testing should be done in order to really have a handle on how many people are infected. And as a result of that, when you see statistics on how many people have had COVID in this country, and it's somewhere around, I guess, it's a few million people. The real numbers of people who are infected are probably anywhere between 3 and 10 times more than that. So probably 10% of the whole population of the world is estimated to have had COVID, but only 1 or 2% have actually been tested positive at the most. Okay, but you can imagine that if tests were more readily available and you could get an accurate result, then in certain situations, like before you got on an airplane, for example, you'd have a test done. And you're starting to see that happening as these faster tests are becoming more available. But keep in mind, with a test like an antigen test, these are these fast tests, that a percentage of people who have the test done who really have COVID may get a falsely negative result. So it's not foolproof by any means. And ideally, for healthcare workers, especially in long-term care settings where that's how the residents have been really restricted in their ability to leave. And as a consequence, how the virus gets into these communities tends to be staff bringing it in. Ideally, we would be testing staff frequently, and how frequently is based on the availability of the test, and similarly on how common the disease is or how widespread it is in the community. Next slide, please. So I'm just talking about conceptually how often you would test if you could and if it was easy and accurate. So, but currently here's kind of how things are going. And many of you are living this if you're working in a nursing home, for example, where states and the federal government are saying you need to be tested this often, depending on certain circumstances. The circumstance tends to be how many people are infected in the broader community, whether or not you have positive cases in a particular nursing facility or assisted living community, and basically, if you have an outbreak, monitoring people to see if you're getting new cases and so forth. I want to talk a little bit about this concept of a test positivity rate, but if you have experienced an outbreak in where you work or where you live, then under those circumstances, generally speaking, it's recommended that everybody get tested in order to figure out who has it and who doesn't, in order to separate people who are infected from those who aren't, in order to prevent the spread, and then also to monitor to see if new people are developing infections. Many people, most of you have probably heard about this concept about this test positivity rate, and this term is actually kind of misleading. Many people think that if they say, well, the test positivity rate is 5% in Virginia, then that must mean that 5% of people in Virginia have COVID. That's not the case at all. What it means is of all the tests that are done on a particular day or a particular week, what proportion of the people who got tested has had a positive result. Okay, so just so we're clear. And you might say, well, geez, 5% of people being tested being positive, 95% weren't positive, so therefore there must not be a lot of COVID around. But 5% is actually a very big number, and the goal is to have it be much lower than that. And so people look at this test positivity rate to see if it's going up or down. If it's rising, that could be an indication that things are really starting to take off and there's going to be outbreaks around. And that results in in recommendations and requirements that testing be done more frequently. The other thing is, if you have a high test positivity rate, it could be that you're just not doing very much testing, and this is what happened early on, and that the only people that can get a test are very, very sick, and so you're only identifying a small subset of people who have COVID, which means you're not really getting a handle on the pandemic. Okay, the next slide, please. Lastly, I just want to say that a couple things to consider when you're caring for people who are living with dementia. People who live with dementia may have difficulty remembering or communicating or identifying symptoms, and so if they're infected, it's less likely to be detected unless they are tested periodically. On the other hand, as I've been tested many, many times with nasopharyngeal, swabbing and so forth, it's not anybody's idea of fun. And if you start sticking sharp things up people's nose who don't know, that's a very threatening thing. And so it may cause more distress in people who have cognitive impairment, and they may not understand what you're trying to do or why. And the same is true for children. And that may cause distress, and people may respond to that negatively in terms that are often pejoratively described as, quote, resisting care. But if anybody came up to you off the street and stuck a stick up your nose, you would be distressed and you would react in a way to try to protect yourself. Okay, so it's very important in this kind of situation that you explain what you're doing step by step, and we're not talking about holding people down or anything like that. Okay, next slide, please. This is my last one. So just to kind of summarize, if we really want to get this pandemic under control, testing really needs to be more widespread and more frequent in order to figure out who has it and who doesn't, particularly among people who don't have symptoms. These rapid tests are becoming much more available, and for most situations and most people, they're going to end up replacing PCR tests. Certainly if we're talking about screening, even though that's not exactly what they were intended for, because when you're just screening people with no symptoms, you're apt to miss some positive tests. And I just want to emphasize enough, if somebody has symptoms and they get a negative test, that doesn't entirely rule out the possibility that they're infected, especially if it was one of these quick tests that aren't as precise. And so if people have symptoms, we assume that they're infected, we treat them as if they're infected, and we try to keep them from infecting other people. And if you get a negative test in somebody who's infected, that may require another test, possibly a PCR test, in order to make sure there's nothing else going on. So thank you for your indulgence and patience. I'm looking forward to answering questions about this, and I hope this is somewhat helpful. Thank you.
Jonathan, that was fabulous. That was super helpful, and thank you for breaking it down for us. So Eric, I'm going to start with you to see what questions you might have for Jonathan.
Just a comment with Dr. Evans. Again, whatever he explained on his PowerPoint, pretty much what we're doing in the building, and with some slight confusion in the beginning, what is a PCR test versus antigen and antibody? Totally different test. That's what Dr. Evans said, they have different results and what's the true science of it. So pretty much, Dr. Evans explained it, further in detail. It was excellent.
Thank you for your kind words.
Great. Al Power, any questions for Jonathan?
Yeah, just a quick one. Thanks again, Jonathan. Both immunology and epidemiology are such dense and complex subjects, and you explain them so beautifully, and your examples are just so clear that I really appreciate that. When I think about how different countries have handled this around the world, some of the countries, and of course it's apple and oranges to some extent, but some of the countries that have done very well have done very aggressive contact tracing, and I don't hear much about that here. What's the situation? Are we just overwhelmed in our ability to do that, or what are we doing with contact tracing, if anything?
Yeah, I'm glad you mentioned that. So that's a critically important tool. And by the way, even though some of these tests are new and they've been recently developed, the basic concepts for how to manage this outbreak go back hundreds and even thousands of years. And so, and these are tried and true things that, when we talk about isolating or, separating people, which we'll call quarantine, and contact tracing, this was done effectively over 100 years ago in the big, influenza outbreak of 1918. So contact tracing basically means if you find somebody who has tested positive, you basically find out who they were in contact with, and you let those people know, and ideally you test them as well. Okay, or at a minimum you have them isolate themselves from others. What I failed to mention though is that if you got exposed to somebody today with COVID, your test would not be positive today or even tomorrow. It may take quite a few days, all right? But there's a period of time in there, again, where you have no symptoms. And again, maybe if you had a test tomorrow morning and it was negative, you'd think, well, good, I dodged a bullet, I don't have it. The next day you could actually be contagious, okay? And nobody knows, and again, you have to have a certain amount of this stuff present in order for the test, because the test just isn't that sensitive to detect it. It's like if you checked your temperature, the temperature is not going to give you a reading down to 1/100th of a degree or something like that. It's the precision of measurement is somewhat limited. And so the point I'm trying to make is that especially early on, if you have no symptoms, that doesn't, and even if a test is negative right away, that doesn't mean that you don't have the disease and that you're not going to be contagious. So contact tracing is very labor intensive. It requires a lot of people to do that, and it requires some skill. And in addition to that, it requires a lot of trust. And all those, and there isn't, unfortunately, very much contact tracing going on, and it relies on people being, completely honest. So, for example, there's an outbreak at a college, right, involving 19-year-olds and so forth, and it turns out that they were at a party and they were drinking alcohol underage, or people were using drugs or something like that. The individual people who tested positive, who got sick, let's say, they may not want to, they might be asked, okay, who are all the people at the party, and so forth. They may be reluctant to say who all those people were because they don't want to, get people in trouble and so forth. So you can see how contact tracing can have its limits, but again, it involves a lot of people and involves a lot of coordination and skill. And as a consequence, unfortunately in this country, there hasn't been a lot of contact tracing. What's been very effective in a lot of places, in other parts of the world especially, is being able to, use cell phone data, or even, a lot of urban areas have video cameras everywhere. And so you can actually monitor where people were. This country hasn't embraced that the way other countries have, and probably never will. But certainly when, like, for example, when there have been big outbreaks like related to these big events like the Sturgis motorcycle rally, people could use this aggregated cell phone data and see where people were sort of traveling to and anticipate the states where there would be outbreaks and so forth. So, but to Dr. Power's point, testing alone isn't sufficient. You have to do something with that test. You have to do something in terms of separating people who are infected from those who aren't, and you have to figure out who else they may have come in contact with, so you can separate them too and take additional steps, additional testing, in order to break this chain of infection. And that's basically involves people distancing themselves from others, and using barrier precautions like masks. And if everybody in the country decided, okay, for 2 or 3 weeks, we're all going to wear masks, we're going to lay low, we're going to have minimal contact with other people, we would not be in the situation we are now. We could break this very, very quickly. And other countries have taken it, every other country practically has taken it way more seriously than we have. And they've taken these basic steps, and now they don't have to deal with the problem that we're dealing with on the same scale.
Wow, that was well articulated. Marla, what other questions do we have for Dr. Evans?
So there's a couple. Some communities have been using 24-hour surface or environmental testing to complement human testing to detect the virus that's been shed between the rounds of human tests. What do you think of this approach?
So I'm glad that question came up, because it reminds me of another thing which is being done, and it also raises, there's a few different things related to this. So let me mention, first of all, some of you might have heard about pooled testing, where you test a bunch of people at the same time with, basically like you combine 5 or 20 nasal swabs that you collected and run it as one sample. That's what you do when you don't have enough testing. And that was a popular idea a while back. Testing on surfaces has come up because we know that the virus can live on surfaces for hours and days. The good news, if you will, is that it probably doesn't get transmitted as much from surfaces to people, especially if people are washing their hands, regularly. And so it doesn't appear that surface to person transmission, and when we call the technical term when we talk about organisms living on inanimate objects like countertops and stuff, we refer to those inanimate objects as fomites, okay? And fomites don't appear to be a major source of transmission, but they shouldn't be discounted. So I would focus my attention on cleaning those surfaces and not really worrying about testing, unless you have a big outbreak and you're trying to figure out if there's a breakdown somewhere else. But it's not something that's recommended routinely because it's a resource issue. I would mention, you probably have read about people testing for the virus in sewage, and that's not a new concept. It's been done for lots of different diseases, and in fact, in colleges and other places, that's how they're figuring out which dorm it's in and so forth, when they're not testing all the inhabitants. So that's another way that it can be tested. The virus is shed in the gut, and so if you test sewage, you can check for it that way, and that's an important public health measure.
So one more question, and then I'll give the details behind it. So the question is, have you heard of a correlation between the extent of contagiousness with CT mean levels? So,
yes.
All right,
Okay.
That's enough to run with, go with it.
Okay. All right, so the CT, it's a big C and a little t. This refers specifically to PCR tests, okay? And as I mentioned, if you think about this test like, baking bread or something like that, and you got to put the yeast in and it has to rise and all that. Well, the polymerase chain reaction occurs in multiple cycles, okay? So it's done repeatedly. You basically, you add the components, you give it a chance to grow, and then you add more components and you give it a chance to grow. So those are, in other words, it occurs in different cycles. And the concept here is that if you were to, if you ran it for one cycle, or another analogy might be, your clothes are really dirty, you throw them in the wash, you take them out and they're still dirty and you got to wash them again and so forth. In this particular case, the fewer number of cycles that are needed to detect the virus implies that there's more virus present in that person, okay? And therefore, people have tried, you know, so I mentioned that these tests are all yes or no tests, or to use the lingo, they're qualitative tests, you know, where things are in one category or another, yes or no. They're not quantitative tests where they tell you how much of this stuff is there. Okay, it's not like if you measure somebody's potassium in the blood, oh yeah, they have potassium. That would be a qualitative potassium test, but we want to know more than that. We want to know what's the potassium level, so we do a quantitative potassium test and it says 4.2, and we say, okay, that's normal. In this particular case, people have taken a test that started out, it's really a qualitative test, yes or no, coronavirus, COVID-19 is present, and they've tried to make it into a quantitative test. Now, these tests were not designed for that. They haven't really been validated for that, but a lot of researchers have kind of seized on this, and people have kind of taken the ball and run with it. This is not something that, in my opinion, is really ready for prime time, and the reason for that is, well, I'll give you a very real world example, okay? About 3 weeks ago, in the nursing home where I'm medical director, we did our weekly testing of all the staff and all the employees. And the good news was 0% of people tested positive, okay? The bad news was that this particular lab, it was a new lab that we hadn't used before, did a control where they tested for the presence of human DNA. In other words, they were testing to make sure they actually got some human cells in there, you know, to see if the swab collection was adequate. And about 40% of the people who were tested didn't have any evidence of human cells in the specimen. And so they, you know, because they tested negative, you can't be sure if it was really a false negative because it was a bad specimen, or if it was truly negative because it is adequate. And so what I'm trying to say is that because of the problem of false negatives related to specimen collection, that's going to mess up the quantitative aspects, or basically being able to say, well, it only took 2 cycles, so we can say that there were 2 zillion virus particles present versus half a zillion or something like that. So this is, again, it's a hot topic, especially in research circles, because people are trying to figure out, for example, who's more contagious. So there was a popular study a few weeks ago that said children at a young age have the highest virus count levels, and therefore they're more contagious than anybody else. But it was using this methodology that really wasn't developed for that purpose. So I take it with a grain of salt, is what I'm trying to say. Sorry, that was a long-winded answer, but just want to make sure people know what we're talking about.
No, that was helpful. I'm going to turn it over to Susan. There's a couple more that have come in, but I think bringing Eric into the conversation, we can address those.
Yeah, at this point, we're at the point of diminishing returns in terms of anything new I can say. I personally am very interested to hear Eric, and I'm sorry I've cut into your time. I'll be happy to answer anybody's questions, and if we run out of time, you can text me or email me, and I'll answer them, you know, personally.
Thank you so much for that, Jonathan. And you really do such a nice job of breaking it down for us. I love the baking analogies.
Okay.
So I'd like to welcome Eric once again. And Eric, as always, we are thrilled to have you share your case presentation today. So Eric, take it away.
Thank you. Let me share my screen. Everybody can see the screen? Very good, thank you. So thank you for inviting me again. I will be sharing our experiences about the testing strategies in the beginning of the pandemic, also our struggles and the current practices, what we're doing now, and the lessons learned. I know it's a short amount of time, you know, we can do this a whole day of conversation of testing strategies. So I just want to give you a quick status, what's happening in New Jersey. The case is cumulative, you know, in state of New Jersey for a small state, you know, we have 208,202. The total PCR tests reported to the Department of Health since the beginning on March is 3,734,094. It's a lot. Unfortunately, there's the mortality, the deaths from COVID in state of New Jersey, 16,106. The current facilities out now, right now in state of New Jersey, long-term care, with active outbreaks is 160 buildings right now. Again, what is an active outbreak according to the DOH guideline is if you have one elder that's positive for COVID, that's an outbreak. If you have one employee that's positive, that will trigger as an investigation. The DOH will come in and inspect the building. Two positive cases of an employee is considered as an outbreak as well. As you can see, the graph is the number of positive cases. As you see, March and April is the peak. Unfortunately, if you're looking at it compared from last month's and June, it's kind of gradually creeping up a little bit, which is a very high alert, for the DOH in the state of New Jersey. The transmission rate right now is 1.19%. Yeah, what is the transmission rate? Transmission rate is the frequency of new infection during a specific time period. 1.19% is kind of high, actually. Last month, it's between like 0.9%. So with that jump for a specific period of time, it's kind of alarming. This is what the DOH is really looking upon. Quick logistics, we're Rockleigh, the Jewish home at Rockleigh and our assisted living is located, but different campuses. We're half a mile away from New York State. And as you can see, Bergen County, during the pandemic, we were the epicenter of pandemic in the state of New Jersey because of the location and logistics. The total PCR test conducted, the Jewish home right now, since we started testing on March, is around 5,360 and change. That's how many PCR tests that we tested in Rockleigh alone. So it's a lot, for an average of 150 elders. Next slide. So as I said, we have two campuses, separate campuses, one in Rivervale and one in Rockleigh. We have an assisted living. And this photo was taken just a couple of weeks ago. Even though, it's the pandemic, we still try to have fun. As you can see in the assisted living, we're having an ice cream Sunday. Everybody likes ice cream. Of course, socially distanced as well, and our elders are wearing masks. And on the right is we're celebrating National Line Dancing Week. Very appropriate for social distancing. So, and then our DJ is one of our CNA, Dominic. So he's the house DJ. So in the beginning of the pandemic, our first in-house case was on March 25th. So we got it very early. And during that stages, there's a lot of confusion and uncertainty in what we're doing because of shortage of supplies and testing kits, actually. So what is the testing strategy in early March? We're testing only symptomatic elders on the beginning of the pandemic. And plus, there's a lot of changes going on. And again, as I said, the testing kits are very difficult to obtain on the beginning of March. Staff members that were symptomatic, and also they had, what doctor said, you have to do contact tracing, who had unprotected exposure to a person with COVID-19. We advised them to be tested right away, and also they will be excluded for at least 14 days on the last day of exposure. The problem with this is, we don't do in-house testing before because, again, of lack of kits and symptomatic staff members were tested in urgent care clinics. Majority of the doctor's offices were closed and they don't have any testing kits as well on March, even until April, actually. Majority of them, they go to the drive-through testing centers. So that's what the scenario was. This photo on the right is one of the testing centers in Bergen Community College in Paramus. They started testing people on March 20th. They're very overwhelmed. We have an employee who came in at 2 in the morning, symptomatic, in a car waiting. This was March. And they open at 8. By 10 o'clock, they close because they ran out of test kits. This was the scenario then. The employee turnaround time of the test result during that time, minimum 6 to 7 days minimum. And unfortunately, these drive-through testing centers were operated by FEMA, not the DOH, not the state of New Jersey. So what's happening is, if we do contact tracing, it's kind of late. It's 7 days above, more than 7 days. And then when you call them, the DOH to report it, there's no paper trail. It's kind of difficult actually. So there's no communication between FEMA and the DOH. Testing kits, as I said, were very limited on beginning of March, and then every morning you see new constant changes in the infection control guidance from the DOH and CDC. So you have to be up to date with that as well. So we tried to brainstorm, how can we get better testing strategy in the Jewish home? So we got this lab, Capstone, this commercial laboratory. They're not in New Jersey. They're based in Atlanta. So what we do is, as what the doctor explained, normally this is sent via UPS. We shipped it overnight, and they provide us as a good adequate specimen collection materials. They gave us enough, to test everyone. And the turnaround time is between 3 to 4 days, which is kind of very good actually during that time. And this is their, if everybody's interested to contact them, this is their website. So when did we start to do mass testing? On mid-May, New Jersey Department did this executive order 20-13. This is what you call the point prevalence testing. This is all indicated to all long-term care, assisted living, residential care, and dementia care houses. It was mandated by May 26. They said by May 26, you should have a baseline testing. So we started a little early. So what is the procedure? All elders and employees should be tested except for all persons who tested positive for COVID-19. So majority of the elders and employees in the building, we have to test them. The baseline must be tested and to be completed, and then the following week, we have to retest them again. Then depending on the testing, we have to do 2 more weeks who had tested negative, so we have to do 2 more weeks of rounds. Then depending on the result from last week, if there are positive results, we have to keep continuing testing the elders and the employees. And there's no positive, they're all negative, we skip it every other week. That's the testing strategy. These are for asymptomatic persons. Antibody testing does not meet the requirements of this executive order. It doesn't. So you have to do the PCR test, either the saliva test or the nasopharyngeal test as well. So the goal of this is to intend the break of the transmission cycle. And also most of the tests that we had results that we obtained, all of the elders and employees are all asymptomatic. And then what we do is we cohort the elder to the COVID area. We give the staff a time of minimum of 10 days. And then again, we do the contact tracing. You have to do after, what you're gonna do after that. You have to do contact tracing as well. So this is the revised example of contact tracing. So what is contact tracing? They revised this on June. They changed it. A close contact means is any person who has, say, confirmed close contact with a COVID-19 person within 6 feet over 10 minutes. I know in CDC they said more over 15 minutes, but in the New Jersey DOH they said 10 minutes. I just want to give you an example of the old algorithm during March. This is how more kind of complex compared to this. They made it simpler. So contact tracing is really difficult. You really have to have someone who really knows what they're doing. Also, what Dr. Evans said, the trust. You really have to take your time talking to the person. What are you wearing? How long did you have contact with? So this is kind of laborious already. We assign a specific person just to do this, just to do contact tracing. And again, they made it very simple algorithm compared to the old one, because the old one, it has mild, moderate, and severe risk. So it's quite confusing. The question, this was a big question earlier. What were we gonna do with an elder who's currently in the isolation and it's more than 10 days, no symptoms? What are we gonna do? Do we need to test the elder, or are we just gonna do the symptom or time-based strategy? Before, there's no specific guidelines about this actually around like early May and late April. So what we've been realized, what the other places are seeing, experiencing, let's say if I tested an elder again after the 10th day, the elder is on the isolation side of COVID side, unfortunately, they're still testing positive. And this is so common. And what happens to that is the elder is not contagious anymore because the elder has no more symptoms and the elder is doing fine. And then what unfortunately, the elder is still shedding the virus, but not contagious. So Unfortunately, the elder has no symptom and staying in the cohort side for 20 more days, which is kind of unnecessary. So what we did earlier was we're not really relying on the test-based strategy, since we know the elder very well. We're doing the time-based strategy, and it's very effective. They just updated this on August 11, as you see, that the test-based strategy is not recommended anymore. Generally not recommended. Just go to the symptom and the time-based strategy. Then we have, again, an updated guidance again in response of resumption of services in long-term care facilities in state of New Jersey. This was implemented on August 17th. You go from phase 0 to phase 3. During that resumption, they also updated the testing guidance again. So if you read number 1, we have to perform the weekly testing of the elders again until there's no new facility onset cases of COVID identified among elders and positive cases in staff for at least 14 days. So you have to do 14 days back to back, have elapsed since the most recent positive result, and during this 14-day period, at least 2 weeks test has been conducted with all individuals having tested negative. So there's a little kind of confusion with this earlier when it came up, but the bottom line is you have to test elders and employees for 2 weeks, and if there's no positive cases that come out after 14 days, we can skip testing the elders. However, you still have to test the staff every week. And also the new guidance is we have to retest all staff who have previously tested positive for more than 90 days. So now you might have the possibility of testing an employee who can show up to be positive again, and we've seen this. I mean, not for the staff, for the elders before. So since when this new directive was implemented, our testing has increased to 53% in comparison to the previous testing strategy. I made a count. The total tests that we did since the updated guidance until last week of September, it's almost 2,000 tests. That's a total of 5.5 weeks. So it's kind of laborious, but again, you know, it's a very effective tool actually, because you're seeing what the clear picture is, what's going on in the building. This is a summary of the point prevalence testing that we did in Rockleigh. This is our elders. If you can see on the first week, the first cycle, when we tested the elders, there's a lot of positive results that came out. They're all asymptomatic, and this is common according to the DOH. Normally, when you do this first point prevalence testing, between 20 to 25%, you will have positive results. But if you looked at it by August 17th, fortunately, we don't have any positive cases with the elders. There's none. Employee testing, on the other hand, since the employee, we have a total probably 300 employees that we're testing in a week, 300. Unfortunately, there's one that's coming out, you know, asymptomatic. So the problem with that is if you have one employee that tested positive, we go back to phase 0 again. So hopefully, you know, this week we don't have any positives, and then we can skip testing the elders. Lessons learned from this. We designated a testing area for staff members. Our social hall, the one on the right, we make a testing area for staff members just to have privacy, because we know this is going to be ongoing for quite a while. We put 3 booths, you know, we put a tarp, you know, in each booth. Also, it's not disruptive in the units. We don't want to test the staff members in the units. We don't want to do that. Purchase backup testing kits. On the month of June or July, between June and July, we experienced, like, you know, there's a lag in delivering of the testing kits since there's a big surge in other states. I mean, the labs are getting overwhelmed from the other states getting performing tests. So we normally have 1,200 test kits in the building, just a backup, and we use them. We use them on June and July actually. We designated a nurse, an extra nurse to assist on testing in addition to the administrative nurses because, you know, testing has a lot of burden and plus the contact tracing, you know, we need backup, we need help. So this really helped us a lot. We designated a clerical personnel just in charge of logging the test results and scheduling of the employees for increased accountability. We want to make sure all our staff are getting tested accordingly and right on time. Be up to date and implement new CDC and DOH guidelines. Very important because every week or two, there's something new. You know, you have to be really up to date. We explored other testing options. The saliva test. Saliva test is quite interesting. This was in cooperation of Rutgers University. They made the saliva test, and actually by April, actually it was FDA approved already by April, I believe. We kind of investigate this. The only issue is when you're collecting the specimen, employees are not a problem because you have to spit on that container. But for our elders, I mean, especially if the elder cannot follow instructions, you know, it's very difficult to collect the specimen. It's a PCR test, by the way. Saliva test is a PCR test. Last month, CMS delivered us this BD Veritor Rapid Antigen Test, which is it's an antigen test, not a PCR test. The total procedure from collecting the specimen to running it is a 20-minute test, very quick. The cartridge costs around $30. It's not reimbursable by the insurance, so think about it. You know, it's $30 a piece. It's less invasive because when you collect the specimen, you don't go all the way up, you know, and you just swab the nostrils on the left and right nostril. The only problem is it's not as accurate as the PCR test, and the DOH is not recommending it for serial routine testing because, again, for accuracy, and also there's a lot of steps. You know, you cannot really do batch testing because you have to insert it on the machine. You cannot leave the cartridge for more than an hour because it will lapse. What we're using is the antigen testing we're using for symptomatic elders and staff. So the good thing is once the elders is symptomatic, we test them. If the elder is symptomatic and the elder tested negative, you still have to cohort the elder. You have to consider that the elder is still, you know, contagious, and we have to back it up with a PCR test. If the elder tested positive on the antigen testing, automatic, we have to cohort the elder. So this is what we're doing right now. You have to educate the staff and the elders the purpose of weekly testing. That's what Dr. Evans said. You know, nobody wants to be poked on the nose every week, and it's quite frustrating actually. So we just tell them the importance of the testing strategy, and as you see, you know, what's happening in the state right now. We see a trend that somewhat's kind of going up again, and plus the flu season is here, so we have to be very, very proactive, and we'll just make sure that we're all doing the right procedures and making sure that the virus is not going to come in the building. Thank you.
Eric, that was incredible, really powerful. So, Dr. Al, you've got the first question. Any question or comments for Eric?
Yeah, thanks. Very quickly, because I know we're running late, but a wonderful presentation, Eric. And every time I hear you present, being in a different place than where you are, I am so astounded at just what you've had to go through the last 6 months, and so impressed at how well your organization has dealt with such catastrophic situations. So certainly my congratulations to you for everything you've been able to accomplish. It was pretty overwhelming at the beginning, not having enough test kits, not being able to keep on top of things. You're doing well right now, but as Jonathan mentioned, mild COVID or early COVID can look like a cold, it can look like flu, and we both know that they're coming. And so the number of people who are going to present for symptoms that require testing is going to shoot up. And do you think you're going to have the resources you'll need for the coming season? Do you feel confident you can stay on top of that increased need for testing that's going to come along?
Right now, actually, Doc, I mean, we have enough supplies, and right now in this state, we're not having any issues such as PPEs, even flu vaccines. When we ordered it, they came right away. The staff are more understanding that, you know what, it's a must. It's mandatory to take the flu vaccination as well. Definitely, we're more ready than compared 7 months ago. Also, the CDC and the DOH guidelines are more specific. You know, they're more concrete. So I think I'm more confident. I think we're more ready. We're facing on this. Hopefully not, you know, with the second wave.
And just very quickly, I was on an AHRQ webinar about testing last week, and they were very adamant about having a dedicated testing space. So I applaud you for doing that, because I think that's a very important thing for people to be doing.
Absolutely. Thank you.
Jonathan, any questions from you for Eric?
Just a couple comments briefly. First of all, I just want to emphasize what Eric described. That is an extraordinary amount of work and an extraordinary amount of resources. And especially when you go from having somebody else do the testing to doing all the testing in-house. And unfortunately, there's only so many people, you know, especially as you develop COVID and people get sick or people are afraid to come to work. And so you can, I'm just pointing out to the group that it sometimes could become a trade-off where if you spend all your resources testing, there are fewer resources devoted to, I'm not talking about Eric, but just in general about there are fewer resources to provide care or companionship or to do those preventive steps. And this is a huge issue in every care setting, even just having to use personal protective equipment, the amount of time that takes, the discomfort and people getting hot. When we isolate people and use PPE, they get less care, unfortunately, especially in situations, ironically, like the intensive care unit, stuff like that. So there's a lot of things that are, it's complicated, a lot of things are connected, but I just thought that was, for people watching and listening, that was a tremendous, extraordinary presentation about how to do things right, okay? And I was listening with admiration and some envy.
Thank you.
Yeah. I think that's how most people feel when they listen to Eric.
Yeah.
So thank you for that. Marla, I'm going to just go to you. We're going to try to capture the questions that have come in so that the recording will include the answering of those questions. So Marla, I think you had a couple there.
Yeah, so this one came up when Dr. Evans was presenting, but it was for Eric. So based on what Dr. Evans shared about testing elders, what has been your experience in testing elders living with dementia?
Fortunately, our elders living with dementia, you know, they're quite open and accepting of testing. But honestly, you know, I mean, there will be 1 or 2 elders that will refuse. And again, the staff comes back, and if the elder refuses, the elder refuses. You know, you don't want to force the elder to do the test. And when this situation happens, you know, you have to put the elder on as an under investigation. You know, you just need to be more proactive, doing respiratory assessments every shift, and also as much as possible, you know, make sure that the elder is kind of more socially distanced with the other elders as well. And again, you know, we're keep in mind, we're testing the elders every week. I mean, it's a lot of testing. And if you, it's okay. I mean, it's okay to skip 1 week and then you can go back and test the elder again. So we have that frequency. So it's not as like, you know, the elder is hasn't had a test in months, you know, but it will happen. Elders will refuse, and we have to respect that.
Follow-up question, is temperature taking good enough for visitors to the home?
Good question, but depending, you know, here in the state of New Jersey, there's different types of visitation, essential caregiver or visits that are end of life or end stage. If the visitor will just go straight in the elder's room and not walking around, I mean, it's not recommended by the DOH or CDC to do even an antigen test for a visitor. They're suggesting it, but it's not mandatory.
Right. That's all the questions I have.
Right.
I tried to,
Did you
I'm
want to
sorry.
speak to the temperature thing?
well, I just want to say, I tried to answer some of the questions, you know, but I typed in some responses to some of the questions. Mr. Robert Bardock, I tried to answer his question a little bit better, but my screen locked up. He was asking about the cycle times, and just to clarify that question, in general, there is some correlation between cycle times and contagiousness. In other words, the more COVID you have, the more contagious you are. But that's still being kind of worked out, as I mentioned. And I just want to make sure I answer all the questions that were directed toward me in a satisfactory way. So if I didn't, please contact me and I'll try to do better. The main thing is we're not exactly where we'd like to be as far as testing, and that is still a problem nationwide, and not just testing in settings where, congregate settings, but testing out in the community, doing, surveillance to see where this is propping up instead of just waiting for people to come in and get a test. So there's a lot more that needs to be done as a nation to try to keep things under control. But the most basic things, wearing a mask, keeping your distance, and washing your hands, those cannot be overstated, and how effective they are. And it's not a political statement. It might be an IQ test, but it's definitely not a political statement as to whether you wear a mask or not. To me, wearing a mask signifies you care about the people around you and you respect yourself, and your life's work isn't done. So I encourage everybody to wear a mask anytime you're not in your home, and that's the best way to feel safe.
This has been a fantastic discussion today. Wonderful presentations. Thank you, Dr.
Actually,
Evans.
if I could just elaborate on that. For those of you that work in care settings, you're used to using protective equipment at work. But let me just say, you hold the lives of other people in your hands. And that responsibility doesn't end when you leave work, because what you do outside of work is going to determine whether or not you infect somebody else. And you do the work you do because it's who you are. You're a caregiver. You part of your life's work is to love and care for other people. And I just want to emphasize that's part of who you are all the time, not just at work. And please, 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 be mindful of that at all times, and in gratitude for your service and in support of that, take the same precautions when you're not at work, because that's when you're most likely to be exposed. So thanks for everything you're doing, and keep doing it, and don't stop.
Well said. I couldn't agree more. And on that note, on behalf of all of us with the Greenhouse Project, thank you for the incredible work that each of you do each day. Thank you once again, Eric. Thank you, Jonathan. As always, thank you, Al, for supporting these sessions. Thank you to all of you for joining us, and we will look to see you again in a couple weeks. Thanks so much, everyone. Have a good day. Take care. Bye-bye.
Great presentation. Great presentation. Thank you.